Hi, this is Mrs. G's case study for the TIA. I'm Lauren.
I'm Danielle.
I'm
I'm
Olu.
Josh.
I'm Sophia, and we'll get started.
So for our TIA case study for Mrs. G, we start off by distinguishing a TIA from a CVA or a stroke. So for a TIA, this often serves at, oh shoot, sorry guys. My bad. Sorry, hold on. I hit something on the keyboard and it started recording my face.
That's okay.
Good thing it's early. Okay. Let's keep going.
Yeah.
Okay. So for a TIA, it serves as a warning sign of an impending acute ischemic stroke. And a TIA consists of a temporary neurological dysfunction, basically stemming from a brief interruption in the flow of blood in the brain. Symptoms of a TIA are tricky because they typically resolve within 30 to 60 minutes, but can last longer than 24 hours. Now, a CVA or a stroke, on the other hand, is an interruption of perfusion to any part of the brain that can cause cell death in parts of the brain. Now, a stroke can be broken down into ischemic or hemorrhagic type of stroke. Ischemic strokes arise from a thrombus, which is a blood clot, or an embolus, which is a dislodged blood clot. Now, hemorrhagic strokes can result from an aneurysm, hypertension, or an arteriovenous malformation. So for the next slide, defining characteristics of a TIA. Other causes of TIA include carotid stenosis, which is hardening and narrowing of the artery that can block blood flow to the brain. And this can be secondary to atherosclerotic plaques and atrial fibrillation. Signs and symptoms of TIA can be easy to ignore or miss, as symptoms can clear up before the patient even gets to the hospital. Now, common signs and symptoms of a TIA include, as far as vision, blurry vision, double vision, condition of one or both eyes being affected, and a phenomenon known as tunnel vision. For motor, the patient could have weak hand grasp, extremity drift, facial droop, and ataxia, which is trouble with walking and balance. For sensory, the patient could be feeling some numbness in the face, feet, hands, or upper and lower extremities, along with vertigo. Now, for speech, the patient could be struggling with aphasia, which is language problems, speech problems, and dysarthria, which is slurred speech secondary to muscle weakness. Now, a patient with the TIA is treated no different than a stroke. They're evaluated in the ED using the NIHSS and the ABCD2 assessment. The ABCD2 assessment looks at age, blood pressure, clinical TIA features, and how long the symptoms have been going on to basically determine the patient's risk factors of having an impending stroke once they've had the TIA. And upon arrival at the ED with symptoms of a TIA, patient labs are drawn, including PT, INR, APTT, lipids as well. ECG is conducted, stat and imaging tests such as CT head and MRI of the brain with no contrasts are implemented.
So when looking at how, my name is Olu. So when looking at how Miss G fits into the profile of a TIA patient, we have to consider the symptoms and the signs and symptoms of TIA. So TIA is classified as temporal blockage of blood flow to the brain, and in order to fit in Miss G into TIA profile, the risk factors and characteristics must be considered. So according to Ignatius, some factors are that can qualify one to be a TIA patient at the age, and it starts from somebody that is 55 years. And when we talk about medical risks, we have something like hypertension, diabetes mellitus, cardiac disorder, hyperlipidemia, atherosclerosis, and carotid artery disease. Again, when we talk about lifestyle, somebody that is smoking and that have sedentary life with poor diet, excessive alcohol consumption, and substance abuse, stress, and some people that are not compliant with their medication can experience TIA. So, and some classified signs and symptoms that somebody will consider a sudden onset of neurological symptoms, which will resolve within 24 hours, like slur, speech, vision changes, numbness, typically on one side of the body, and loss of coordination. So, fitting Miss G into this profile, we're going to say that from the information that we have, Miss G is she is 59 years old. She experienced sudden slurred speech with facial drop on one side, this right-sided numbness in the face and arms. So, and the symptoms were resolved within 24 hours of admission. So, this is what fit her into the profile.
To identify Mrs. G's predisposing risk factors for a TIA and possible stroke, the first one we have is hypertension. Mrs. G's blood pressure in the ER was 148/97, which is elevated. Hypertension is one of the strongest modifiable risk factors for TIA and stroke, as it puts stress on the blood vessels and increases the risk of vessel rupture or blockage. The next one we're going to consider is her age. As she is 59 years old, she is at higher risk for a TIA or stroke. The third risk factor we'll consider is possible hyperlipidemia. Although her cholesterol levels are not yet provided, the fact that a fasting serum cholesterol is ordered suggests concerns about her lipid levels, which, if they are elevated, can contribute to atherosclerosis and stroke risk. The next one we will consider is her gender. Women have a slightly higher lifetime risk of stroke than men, and certain female risk factors, for example, postmenopausal changes, hormone use, can contribute. The next one is transient neurological symptoms. So the sudden onset of facial droop, numbness, and speech difficulty are hallmark signs of a TIA.
Okay, which of her risk factors can Mrs. G change and which are beyond her control? The risk factors that she can change are her hypertension and her elevated glucose level. Her blood pressure is at 148/97, while her glucose level is at 105. And this isn't too high, but it's in the pre-diabetic range. And she can work on managing both through lifestyle changes like diet and exercise, as well as medications prescribed by her doctor. As for unmodifiable risk factors, that would be her age at 59 years old and her female gender. Next slide. Thank you. And Mrs. G is placed on IV heparin to assess for bleeding and possible hemorrhage. What does the nurse need to monitor while she is taking this drug? So, heparin is an anticoagulant, meaning that it helps prevent blood clots, but it also increases the risk of bleeding. So, the nurse should closely monitor her prothrombin time and her INR. These lab values help assess the blood's ability to clot, where a prolonged PT or elevated INR could indicate a higher risk of bleeding. So her INR value is 1.1, which is normal, and her PT is 12.9, which is slightly above the normal range, with the max being 12.5 seconds, but it's not above the critical value of 20 seconds. Regardless, both values need to still be continuously monitored during heparin therapy. Next, the nurse should monitor platelet count. Heparin can cause a condition called heparin-induced thrombocytopenia, where the platelet count drops significantly, and this would then increase the risk of bleeding. So Mrs. G platelet count is currently 294,000, which is within the normal limits for now, but it should still be monitored. Next, the nurse should also monitor hemoglobin and hematocrit. A sudden drop in either level can indicate internal bleeding, and right now her hemoglobin is 14 and her hematocrit is 44%. Both are within normal ranges, just regular monitoring needs to be continued. The nurse should also monitor for any clinical signs of bleeding, such as bruising, especially if it's unexplained or excessive, nosebleeds, gun bleeds, blood in the urine, dark or bloody stools. And lastly, the nurse should monitor her renal function. Since heparin is processed through the kidneys, it's important to monitor renal function through the serum creatinine and blood urea nitrogen, or BUN levels. Right now, her creatinine is 0.8 and her BUN is 15. Both are within normal limits, but should be closely monitored while on heparin. Next slide.
So the major complication associated with her TIA is a stroke, because a TIA is a warning sign of an impending or possible stroke. And the strokes that she could suffer are most likely an ischemic stroke, which is a temporary block in blood flow, or a temporary occlusion in the vasculature. Some other complications that may occur include swallowing problems, UTI, DVT, mobility problems, or falls.
Okay, so for our 4 nursing diagnoses, our first one is risk for ineffective cerebral perfusion as evidenced by brief interruption in cerebral blood flow secondary to transient ischemic attack. Our second nursing diagnosis is risk for bleeding as evidenced by anticoagulant therapy and ongoing need for PT, INR, and platelet monitoring.
The third diagnosis is risk for aspiration related to impaired swallowing reflex or dysphagia following neurological symptoms. The fourth one is risk for injury as evidenced by a need for possible assistive device like walker, wheelchair, and more, a safe environment like removing rugs, putting on light at night when working, and providing a caregiver assistance.
And then how we will integrate new knowledge into our personal nursing practice. So considering all the information that we have gathered regarding TAs, we can effectively incorporate our new knowledge by using certain assessment tools like the NIHSS or the ABCD2 assessment, recognizing those silent symptoms that we mentioned earlier, and also some silent symptoms such as blurred vision, diplopia, ataxia, vertigo, aphasia, numbness, or dysarthria. We can also promote lifestyle changes like increasing mobility, physical activity, stopping smoking, including a more balanced diet, and then we can also understand potential medications that may be prescribed, like antiplatelets, like that was mentioned earlier, in some hypertensive meds.
Here are our references. Thank you everybody for your time.